guys, this is the TheASMRMedic. I hope you're well. I was asked quite recently in one of my medical videos if I could kind of run through how I revise generally for my exams and just throughout the year, I suppose. And I thought that it'd be quite a good video actually for you guys. So we're gonna do a kind of revise with me session, I suppose. I've got a ton of topics that I need to make notes for. As you can see, I've got all of these that I still need to do. There's a bunch more I need to add on to this as well. The only one that I've actually completed is my respiratory diseases on this section, so there's a lot to do, and it could be quite interesting to take you guys along with me for these sections. These ones are quite interesting, but I guess before we get into that, I would like to say that I revise in a number of ways, as do many people. I like to take notes. That's the way that I revise. I guess short term, it's definitely the way that I cram revision for exams. So the 3 or 4 weeks leading up to an exam, I'll just be taking notes, repeating the notes over and over and over again. But in the interim periods where there's not that much time pressure, you guys know that I love to make illustrations. There will probably be some links in the description to what I'm talking about. I do a lot of drawing using my iPad, and I like to annotate my drawings to help me revise. I also take a lot of note cards. I find note cards very useful. I have a stack of probably, I would say, 300 or 400 note cards that I can show you guys at some point. Hopefully there's a video playing of me showing it to you, actually, just a kind of overview of them at least. And if you want, in a video, we can go through those together. But yeah, I thought this video, it could be perhaps more interesting to go through how I approach learning or revising a specific medical topic. So usually it will be a medical condition. I've already done a video where I go through, I think I went through asthma, but I wanted to go through many of the respiratory diseases. We're going to do more videos on that at some point. So for example, one condition was asthma, and then I would take down, that's correct, I would take down some useful links to refer to. Then I would do a summary, which has a kind of overview, then the specific pathophysiology of the disease and how it occurs, the signs and symptoms that are associated with that disease, the investigations that at least a medical student at my level, I'm in 3rd year at the moment, but these notes are actually from 2nd year, diagnosis and differentials that you should be aware of. So how do you diagnose, or at least what are the criteria for diagnosis, and then the standard kind of differential diagnoses that you could make, I suppose, based on the information you have. And then usually lastly is management, so how do you treat said condition? And as you can see, there is quite a lot of information to take down. A lot of it seems like a lot of stuff to remember, a lot of stuff to have to remember for many different diseases. For example, this is interstitial lung diseases. There's a number of these diseases, not just one. There's tons of differentials that you need to remember, and the differences between them, the clinical features, so symptoms, things that are kind of only associated with certain conditions, the clinical exams, and what you should expect to see if you do come across a interstitial lung disease, the risk factors. There's tons of stuff to do with the investigations. I mean, x-rays and CT scans, and obviously there's so let's start off by what are the symptoms. Okay, fine. So here we are. You've got the NHS website, which is the UK's National Health Service. You have the Mayo Clinic, which I think is like an American thing. Bupa, which is like a private medical company in the UK, healthcare company. Heart.org, which is, I think, more of we've got the British Heart Foundation there as well, which is a charity. I think Heart is also kind of a charity. It's like just an information thing, the American Heart Association. These are, if you start reading them, you start to realise that they are meant for the general public. They're generally speaking in layman's terms, which is brilliant. Cleveland Clinic as well, Medical News Today, Healthline. None of these things are where you as a student want to be going. Generally speaking, if you want to get an overview of the subject, what is the condition, fine, you go to these places, have a little read, just get an idea of what the condition is. But it's not really where you want to be revising, if that makes sense. Because you're not going to get in-depth pathophysiological detail, you're not going to get good differentials from these things, you're not going to get, how do I approach a patient with this? It's more from the patient side. It's, do you think you have pericarditis? And should you go and see the doctor, basically? Or if you do have pericarditis, here's the reasons why, or why you shouldn't be worried. That sort of stuff. So there are a number of good online resources that you can use. I'm going to be giving you my favourite. I always check Geeky Medics. Geeky Medics is a UK-based company, and they do brilliant OSCE guides. OSCEs are the history taking and clinical examinations. That's what they are. They're examining our ability to carry out clinical examinations, history taking, all this sort of stuff. And quite often they also have a number of good just topic overviews. So for example, I used to just go to their clinical examination pages because they are very, very good. But now they have a lot of medical topic overviews. So you can have a look at, let's just pick one randomly, I don't know, pulmonary hypertension. That's a pretty good one. That's one that you should probably know quite a lot about, especially in third year. So a lot of them, most of them, they've all been written by people with experience. This is by Dr. Rhea Smith, whoever that is, and they give you the sort of overview that you might be familiar with from my note taking. So an introduction, a kind of a summary, I suppose. Maybe a slightly less in-depth summary than what I take down. The etiology, which is basically the pathophysiology, kind of. It's basically as much pathophysiology as you really need to know. You don't need to go into much depth with that. The risk factors, the clinical features, the investigations, the management, the complications, and then some key points at the end, which is always nice. Some sort of salient points you should definitely take away. And I check here because they break things down into appropriate amount of detail, I would like to think. And they usually have something on a subject that you're interested in. But say for example, acute coronary syndrome. That's quite a good one. Maybe we could have done this, but I would quite like to go for pericarditis. Maybe it's good actually that they don't have it, because then when you can't find the thing that you're interested in, what do you do? Well, I will show you what I do. So let's I actually wish they had a search feature. They do. Pop pericarditis. Usually they have something related to it in some fashion, but I don't think that they actually have a pericarditis. They have the cardiovascular history taking, which is very important to know. The ABCDE emergency medicine approach, also very important, but nothing specifically related to pericarditis. So, fine. There's no pericarditis here. What do? I use Ambos. that big of a deal if you're in the UK, because most of the time it's interchangeable. They have American spelling, but if you're from the UK, you probably can recognise that quite easily. But the big difference is things like specific diagnostic criteria and treatment pathways. So, diagnostics, when you're starting off as a student, diagnostics can kind of seem like this fun sort of investigatory type thing, and it is. So it is slightly like that. But as you start differentiating between similar conditions, so this might not be that appropriate for pericarditis, but if you're trying to distinguish between two very similar I don't know, cardiovascular diseases, two very, very similar types, the diagnostics will have specific NICE guidelines, NICE guidelines in the UK. So if I make a diagnosis of condition A over B, is because the patient is exhibiting certain diagnostic criteria that is not present in B, or vice versa. So, if you're looking at American diagnostics, they may not be appropriate for the diagnosis of the condition in the UK. A lot of the time, that isn't true, because we're very, very similar, the US and the UK, and medicine is medicine, but we have very different medical systems, healthcare systems, and that's worth just taking into consideration, especially with treatment, because the treatment for, so let's have a look, what do they say? So here it's saying NSAID therapy, and that's pretty across the board, but for things like this, I would just, take note of it, because it's usually correct. NSAIDs, or at least correct in the UK, they are the right sort of medical therapy for a lot of cardiovascular diseases, and especially in this case, pericarditis. Enough about that. Let's actually start having a look at it. So, as you can see, there's so much information, and you don't need to be taking all of this down. The pages can be way, way longer than this. They can be way longer than that for more, I guess you could call it, difficult conditions. There we go, finally managed to get it's quite difficult actually typing around my microphone, but we will get there. So let's have a look at the summary. So pericarditis is inflammation of the pericardium that may be acute or chronic. So that's really the most salient point in terms of what is the condition. So we all know that itis, or if you don't, here you go, itis conditions, things that end in itis, they're basically always inflammatory. So if you think of cellulitis, that's just an inflammatory condition of the skin, and there are colitis, as inflammation of the colon. So pericarditis is inflammation of the pericardium. This is why I like amboss as well, is because you have these nice little drop downs. The pericardium is a layer of the heart. So the pericardium is the fibroserous sac that encloses the heart. The layers include the serous pericardium, so that's the very inner layer of the heart, which is the layer we're talking about, which is further subdivided into a visceral and parietal layer, and the fibrous pericardium outer layer. We're not going to get into too much detail about that, we just want to know about the condition. It's always nice to have a good background, but here we are, I suppose. So I like to copy this, and I will add that somewhere here. So under pericardium I'll have amboss, and there we go. Actually, what you can do, which is quite nice, on Notability on Notion, is that you can hyperlink things. There's a ton of different things that you can do actually. I always like to colour code my symptoms. So this is just a summary list of symptoms. It's going to be more in depth and more, I guess, specific symptoms later on when we get to it. So, yeah, fever. These drop down to quite nice because you can just kind of make it look nice and neat. Fever, pleuritic, chest pain. I'm not going to get into what these things are. So things like pleuritic chest pain, we'll leave the description of what these are for a later video. Otherwise, we're probably never going to get through this video. And pericardial friction rub on auscultation. So pericardial friction rub on auscultation. The diagnosis. So now we're into diagnosis. You see how things, they always break it up into these kind of salient blocks of information. So diagnosis is established based on clinical findings. So based on clinical findings, things like these symptoms and signs and examinations based on clinical findings. And that's different to well, let's go into it. So although diffuse ST segment elevations on ECG and imaging may support the diagnosis, so many conditions, the condition or the diagnosis is made based on investigations. So an investigation would be an ECG, that kind of boom, boom, boom that you see, an electrocardiogram, you know, the thing that looks like this. Because like, I don't know what to call. I don't know. If you don't know what it is, just have a look on Google. You'll know what it is. Everyone knows what an ECG is when they see it. Or it could be like urinalysis or blood cultures, things like that. Those are investigations. A clinical finding, however, is more like a symptom that you've identified in a patient, or a sign, which is slightly different to a symptom. A clinical finding could also be a clinical examination of a patient. So if you're doing auscultation on a patient, that's what this is, auscultation, or percussion on a patient, or just having a feel, I suppose, of the patient. Those are all clinical findings as well. So although ST elevation is a very common, what I've seen anyways, very common ECG finding in a lot of cardiovascular diseases. So ST elevation is never good. ST elevation supportive and imaging. Why not just pop that in there as well? But yeah, this is very, very basic information. But like I said, that's kind of what we want from the summary. Acute pericarditis is usually self-limiting or self-limited, lasting days to weeks, and it is therefore managed symptomatically fine. If pericarditis lasts longer than 3 months, it is described as chronic pericarditis. Chronic pericarditis may either be constructive or effuse constrictive. Now, I actually don't know what these things are, so this is good revision for me, or learning, I suppose. Constrictive pericarditis is characterized by thickening and rigidity of the pericardium, resulting in both backward and forward failure. Yeah, this is all news to me. I do see some signs actually here though, so we can maybe put that, let's take it one step at a time actually. So diagnosis, let's go, what should we call it, sub categories. So we have acute and chronic, and acute is a self-limited, so days to weeks, and it is treated and sign, say over 3 months, and either constructive or effusive. Constrictive. Okay, cool. Let's have a look at these then. So we have constructive, which is characterized by thickening and rigidity of the pericardium, resulting in backward and forward failure. Patients typically present with fatigue, jugular vein distension, peripheral edema, and a characteristic pericardial knock on auscultation. I've never heard that before either, which is caused by a sudden stop in ventricular diastolic filling. So I've turned constrictive into a drop down because we're getting quite a lot of information in this now, and it says that it's characterized by JV distension. I'll put these into one. Peripheral edema. So edema is spelled differently in the UK, and a characteristic I'm actually going to put this into its own thing. Pericardial knock on auscultation caused by sudden stop in ventricular diastolic filling. Okay, fine. Good to know. I'm learning. Effusive, constrictive pericarditis. So this is the next one. We're obviously going to get more information on these later. Although I don't know how long we're going to go on with this, but you can kind of get the idea of how I'm taking down the notes, I guess. Effusive constrictive pericarditis, characterized by, yet again, a thickening pericardium with effusion, as the name suggests, as opposed to just standard constrictive pericarditis, and this can lead to cardiac tamponade, which is very, very dangerous. So it may manifest with symptoms similar to constrictive pericarditis, symptoms of pericardial effusion or cardiac tamponade in both constrictive. Okay, fine. So that's all good. And then we'll just make a little note here. In both conditions, imaging is used. Imaging used to confirm diagnosis. Fine. And then under management, just a little sentence consists of treatment of heart failure. That is things like diuretics and pericardiectomy. I'm guessing that is something to relieve the pressure. The complete or partial removal of the pericardium. Oh wow, used to treat severe or non-transient constrictive pericarditis. Okay, so I'll make sure that my thing is on mute because I'm going to have a quick look at this. Okay, so this is a good example. So this is osmosis. Osmosis is a brilliant. Let me just take the link down. Osmosis. If you don't know what osmosis is, I highly suggest. Just copy it, whatever. I highly suggest going and checking out their videos. They make brilliant content. I would love to make content like that. I'm actually in the process of making a video sort of like the way they do it, but obviously they use amazing graphics that I could never make on my own, I suppose, without at least some sort of proper software. And yeah, it's really great information. So what I would suggest is, if you do find a video, I would take it down and go like this. I take down there. Obviously, then whenever you click that, the video will come up quite nicely, and you can just watch this, because they will have absolutely tons of stuff on symptoms, diagnosis, and just usually it's just simple stuff. That's really useful to know. So let's go like this. Osmosis. At least I think it is osmosis. It certainly looks like their content. Okay, it's not letting me do that thing. Oh no, here we go. There we go, perfect. So now we can just click on that link and off we go. So there we go, there's the summary done. Pretty simple. Obviously it would be a lot quicker if I wasn't kind of narrating what I'm doing. So now we have our definition. So we have acute pericarditis. Information that is either isolated process or concurrent myocarditis, transient constrictive, chronic pericarditis. We've already kind of looked at most of these things. So I'm just gonna go past this now. Things like perimyocarditis, I don't even really know what that is. It sounds like it's peri and myocarditis together. Maybe I'll go back and sort of throw a few of these things in here, but not really that useful, I suppose. Not really sure why it's not letting me open up this image, because I like to get some of the visuals into my page as well if I can. So it's quite odd. Maybe I need to refresh the page. I have no idea why this is not allowing me to open these up. Weird. Whatever. Anyway. So etiology. I'm going to ignore that for now, because it's the least important information that you need from any of these things. So first of all, anyway, it's saying idiopathic, so it's a descriptive of things that are sort of an unknown pathophysiology, so it's not really that important anyway. We know that already it's most commonly viral, can be bacterial, and then very rarely fungal. Myocardial infarction as a sort of a resulting feature, and then a bunch of other stuff. So I wouldn't, if you're going to miss anything out, I'd miss out the etiology. So now we move into the clinical features. So this is the good stuff. The clinical features. We know that we're breaking it down into acute, and I'm guessing chronic, and then the effusive constrictive pericarditis. So acute pericarditis, chest pain. So that is pleuritic. Acute sharp retrosternal pain caused by inflammation of the parietal pleura. You can write this stuff down. It is useful to know. I probably just put retrosternal. That's just maybe as much as you need to know from that, I suppose. Aggravated by coughing. Some of these things can be quite useful to know, because or swallowing actually. Or deep inspiration. Because they might put that into a question on an exam. Sort of, this patient has pleuritic chest pain that gets worse. When he coughs, it feels worse or something, And you should be thinking, oh, acute pericarditis. So, fine, good. Other causes of pleuritic chest pain: pulmonary embolism, myocardial infarction, and pneumothorax. That's quite good to know, but we'll probably leave that for the differentials. Improves on sitting and leaning forward, so that is a really key point. That's why they've made it big and bold. And as a result, so will I. So I'll show you what I do. Improves on sitting and leaning forward. That is key. So what I like to do is I like to So let's actually, these guys need to be under like that. And then we have, so pericardial friction rub, which we talked about before. Briefly, I don't know what it is. It's a high-pitched scratching on auscultation. I might actually just bold that. I might bold the chest pain as well, just so we have a nice kind of visual list. Best heard over the left sternal border during expiration while the patient is sitting up and leaning forward. So I'm actually just going to do a comment for that. So left sternal border during expiration while sitting up and leaning forward. Send, and then these things I don't think I really need to know just yet. So indicates friction between the visceral and parietal pericardial tissue. Fine. Very good. Then we have pericardial effusion. Okay. These are. I'm not even going to put anything in there because I already kind of know what that is. And then low grade intermittent fever. And we have some other small things as well. So we have Tachypnea. I actually don't know how to pronounce that properly. Which is just fast breathing, basically. Abnormally fast breathing. Dyspnea, which is sort of irregular breathing, again pathologically, generally pathological, I suppose. And then a non-productive cough, so a dry cough. Okay, fine. I'm actually going to move on though. So we've got chronic pericarditis, and we also have the constrictive, or is it effusive? Effusive constrictive pericarditis, but we're gonna crack on so that we can at least get somewhere with this. So I'm not leaving you for a second part. Diagnosis. Okay, so again we'll just stick with acute pericarditis because obviously there are differences between them all. And this does give us quite a nice little breakdown, doesn't it, for each different thing. We're looking at each of these individually. So acute pericarditis. So we've got the approach, the diagnostic criteria, and then the ECG, which they were talking about with imaging confirms. It's a real shame I can't click on these. Oh, here we go. I think maybe I was just being impatient. Or is that the only one that's opening? They are opening, that's good, because then we can take these down as examples. So, right to the approach. So ECG and TTE. What is TTE? I don't know. A transthoracic. Oh, it's an echo. Is that just a standard echo? I'm going to put echo for now. Because I know what an echo is. I've not known it called a TTE though. Maybe it's different. Diagnostic criteria. I don't know what that is though. We're going to have to look at the NICE guidelines. If TTE is inconclusive, consider a CT ways of looking at an ECG, I suppose. And PR segment depression. I actually don't know what that is. I mean, I can guess, but I don't really know what the significance of it is. Stage 2, ST segment normalizes in around 1 week. Stage 3, inverted T waves. And stage 4, finally, ECG returns to baseline. Weeks to months. Okay, so let's have a look. Maybe they're going to show us. I was hoping they might. Signs of tachycardia, normal heart axis, P waves of normal morphology, concave ST elevation, best seen AVL. Let's see if we can get a better look at this. So, I haven't looked up these in a long time. Okay, so I think that this is the ST elevation here. This bit here. QRS. No. It's not that, is it? PQR. Oh yeah, it's the QRS complex. Here you go. From the S to the T. QRS. And this bit here. Is it called the QRS complex? Here you go. This is why I like to go through it. ECG annotated. Let's have a little look. Okay, yes, it is the QRS. And look at this. ECG interpretation. Geeky medics. Okay, so I'm actually not going to take these down, but usually what I would do is I would screenshot these and then or copy and paste them into my thing just to get an idea. Maybe I will copy this one just out of general interest, but I would do a nice little caption on them because you can do comments and whatnot. So yeah, that's the way I would go about it anyway. Or maybe I'll just link it. But there's quite a lot of things like radiography.org or radiology.org, where it's called Teach Me Radiology, something like that. But yeah, lots of different resources you can use. So imaging. This is more of the same though. Okay, well, I tell you what, guys, I think we'll probably just leave it there actually now. We've gone on for quite a while, and I really approach it by much the same way. For things like diagnosis and management, like I said, I would go and check your own guidelines that are relevant to your own country, just to make sure that they're at least along the right lines, and if not, I would, well, either way, I'd still link yourselves to those. For example, if you're in the UK, link it to the NICE, the NICE guidelines, and have a look yourself, and sort of structure the way you write it based on that. For example, these stages, I don't know if they're actually relevant to the UK, so I will go and have a look at that. But guys, I hope that this helps. I hope this gives you a good idea of how I would approach it, and let me know what else you would like. Just as a quick shout out, this was actually asked by Trevor Williams. I'll make sure to pin a comment below. Just to thank you for your suggestion. I forgot to say thank you at the start. I said thank you to the idea. I forgot to actually give you a shout out. So thanks again, Trevor. I just realised now that you actually asked what specialty I'm interested in. I'm interested in doing emergency medicine, and if you guys would like